Good evening, everyone, and welcome to all of you for webinars by IITACB. And as all of you know that this is a unique center to establish a networking platform for both academia and industries, as well as among the industries through a lot of, the socio-important projects. So we are conducting this webinar series on healthcare, and this is the second part. And so basically, the aim of this series is to, open a dialogue between healthcare consumers, and consumers are clinicians, administrators, and eventually to the producers, which are technologists and startups. So aim is to have a discussion on this who, where, what, to bridge the gap between the innovation and implementation. So today we have two speakers, and so Dr. Sai Vivek, who is a consultant medical oncologist working at Aster Hospital, as well as he's working with Dr. Ravi Bhardwaj, Mr. Ravi Bhardwaj in the same field. So he has an enormous experience of 8 years in this field, and he actually gained his MD and DM degrees in oncology, and then he went to UK and obtained his MRCP in medical oncology, and he was first to enroll for Masters in Precision Cancer Medicine from the University of Oxford. So that's wonderful. And his mentor was Dr. Patil, who's well-known well-known oncologist. So Dr. Vivek's clinical and academic interests basically lie in integrating precision medicines into routine oncology practices to improve the patient outcome. And he's actively also publishing these research outcomes and innovations. So basically, he's also working with a lot of engineers, technologists, then clinical side software data scientists and users. So pretty much he has gained a lot of knowledge from all the perspectives, and that actually helps him bridging the latest in cancer genomics with practical and patient-centric care, and making him a leading voice in the evolving this technology. So the second part of the series or today's webinar will be again by Mr. Ravi Bhardwaj. So those who missed attending the previous webinar, so for them, Mr. Ravi Bhardwaj is a senior director of product management for GE Healthcare's oncology solutions, and he has 25 years of experience in this healthcare industry. So he's a so basically his interest lies in the developing cutting edge digital technologies to improve this cancer diagnosis and the treatment, and he uses these AI driven solutions to enhance these clinical outcomes. And basically he's advocating for the approaches those have priorities for the needs and experiences for the patients. So he's well connected in that one. So he in the previous series or the previous webinar, he talked about how technology, data, and devices can make a meaningful impact on medical solutions. And taking forward to that knowledge from his talk, now we are going to have this, the advancement towards this precision oncology, and talking and having discussion among these two. So today's webinar will be co-hosted by Dr. Sushila Venkatraman, who's a Joint Secretary IITACB, and myself. And for audience, please post your questions in Q&A box, and that will be taken up during the discussion, during the breaks. So please don't forget to do that. So over to Dr. Sai.
Yeah, good evening, everyone. I would firstly like to thank IIT ACB and Mr. Ravi for giving me this opportunity to talk about something that I'm really passionate about. And it's wonderful to see so many people joining in to talk about oncology and especially precision oncology. So, with that said, and I'll just go ahead and share my screen. And I'm hoping that my screen is visible and I'm clearly audible.
Yes, sir.
So,
You're audible.
yeah, yeah. So today, in the next 20 minutes, we are going to briefly touch upon what is precision oncology. Everybody knows oncology is equal to cancer. What is precision oncology, the new era that we have stepped into, and that's going to be the way forward for the next decade or two, and how we can make it much better in India and make sure we are the global leaders in terms of precision oncology. Yeah. So my disclosures, yes, I did take some help from AI. Thanks to all of you. The prompts are from me, but yes, there are some helps from AI that I've taken to make this presentation. Any of you can just stop me at any point. It doesn't stop my flow. You can clarify any point then and there, or leave it at the chat box as suggested by the organizers. So this is going to be the presentation overview. We'll quickly touch upon all these points and we'll try to conclude about what are the unmet needs that are there in this particular field and where we can collaborate healthcare and technology to make the outcomes better. So before we step into any of the scientific stuff, so this is a simple cartoon on the slide. So when we talk about a tumor, all of us think lung cancer is one, and breast cancer is one, and oral cancer is one. There is a concept called spatial and temporal heterogeneity. That means when you're talking about a tumor of, let's say, 10 grams, each cell is heterogeneous in terms of the DNA changes that have occurred in the cell. The main driving pathway in that particular cell is completely different. That is the reason why we are not able to cure cancer. When we are dealing with 100 cells, if you have all the cells to be homogeneous and one drug can kill all of it, we would have found a cure for cancer long back. But if you have 100 cells, 20 of them behaving in one way, 20 of them behaving in another way, if you use a drug which kills 20, the other 80 are going to grow, and vice versa. So that is the main challenge, understanding the predominant driving force between the growth of each cell is known as heterogeneity that we are seeing. That happens in space. When I say space, it means in a particular cell, depending on the area that we are biopsying, each cell can be different. If you're talking about lung cancer, which has started in the lung and gone to the liver, the character of the cells in the lung is different from the character of cells in the liver, but both of them are still lung cancer. So that is the challenge we are facing. When I move on to temporal heterogeneity, it means someone has cancer, we have treated them, all the scans are showing that the cancer has gone away, but there is a recurrence after a year or two. And the cells which are making up this recurrence might be completely different from the cells which initiated the cancer. So DNA is such a rapidly changing molecule that at every cell division, it can accumulate more damages. And this particular damage, also known as genomic instability, that we call it in our clinic, this genomic instability will give the next clone of cells that much more ability to resist the conventional treatments that we have. So, though the drug industry is rapidly progressing, the tumor unfortunately is smarter and progressing faster in terms of how to beat the treatments that we have. So that is the main challenge. And precision oncology, in a way, tries to address these two parameters that we started off talking about by various methodologies, which we will be talking about. So when we talk about precision, you can call it like a tailored treatment. It's like a bespoke thing. You go to a tailor, it's not ready made. He takes your measurements, he makes something especially for that particular individual. So, when we are talking about precision oncology, it means not only are we looking at the genome or the DNA of the cell, we are looking at what is happening to the genome when it is being converted into the protein and how this protein is behaving in the cell. So the central dogma of molecular biology is you have the code, which is the DNA. From the code, a message is sent to the protein manufacturing unit of the cell. That code is known as an mRNA. The mRNA goes to the factory which is called a ribosome. This ribosome makes proteins, and along with the DNA, there are something known as epigenomics, which controls the way the gene behaves. So it's not a single point, there are multiple dynamic factors at play. So when you consider all these parameters, which actually result in the phenotype, to put it, is the final output, that is the cell. How does the cell look? How many number of proteins does the cell have? Is it big? Is it small? That is known as phenotype, or the actual appearance. What is responsible for the appearance are the parameters above it. So precision oncology is where you try to test one or two of the parameters that we saw, understand the phenotype, and start developing a treatment strategy based on the information you get from this, not from the conventional lung cancer is equal to chemotherapy, lung cancer and mouth cancer is equal to surgery. No, you deep dive, understand better, and try to see which is the driving force. And hopefully, if you find a medicine to that, use that medicine to get better outcomes. So, as we were discussing, it is personalized care using the molecular profiling information of not only the genomics, the other omics also, like proteomics, transcriptomics, epigenomics, and metabolomics, and more recently microbiomics. So what bacteria we have in the gut that all of us are carrying are very different depending on the diet we are in, and what bacteria is there is actually affecting the treatment response of multiple drugs, including immunotherapy. So it is so much variable in terms of person to person. So getting all this information is the first step. Then you do guided treatment. This becomes the most comprehensive approach to beat the heterogeneity of cancer. So if I have to put the core elements of precision oncology, of course, it has to start off with profiling of the different omics, identify a biomarker which tells me what treatment to use the specific targeted treatment, try to beat the cancer. Not only that, we also can use all this information to prevent a recurrence or even detect a recurrence before it has actually occurred. So that is the true value of precision oncology. One, screening, early detection, and more comprehensive approach to treatment, if you have to put it in three particular compartments. So it didn't start 5 years. We have the era of precision oncology started 20 to 25 years back, when we got the first targeted therapy for CML, which is a blood type of blood cancer, a single drug, which is now worth, I would say, less than 2,000 rupees per month, has actually cured a cancer which made the lifespan of these patients to be less than a year. Now, patients who were started on the drug in 2001, at 2025, they're hale and they're healthy, and they're actually able to live a good quality of life. Such is the impact from 1 year to nearly 25 years, just by the evolution of genomics, that we found there is a change in DNA happening in these guys, and a single drug can actually be able to almost keep it under control, if not cure, for decades together. In 2010 and 15, that's when the diagnostics took a huge leap. So we had billions of dollars spent from 1990 to 2003 to sequence the human genome. That is known as the Human Genome Project. That was published in 2003, a collaboration between US and UK, and they spent billions of dollars. In 2008, we started sequencing the cancer genome. So you need to have a reference to compare what you're sequencing. So you have the Human Genome Project, which is the normal genome. You have the Cancer Genome Project, which is the next level of reference. Then whoever is being sequenced now, their DNA is compared to the reference library, and then we start calling out variants. Okay, this is a normal variant. This is a pathogenic variant or a disease causing variant. Then you start developing treatment to that particular variant. So in 2015 to 2025, we started treating it not by the cancer name, we started treating it by the findings that we are doing in terms of the next generation sequencing. That is the technology used, where parallelly we can sequence millions of DNA fragments, detect the mutations that are present in DNA. That is the code, so corrupted code. Not only that, now liquid biopsy is something where if you have cancer in the body, it is going to shed. So it sheds the DNA into the blood. Either when it's dying and shedding the DNA, or when it's replicating also it sheds the DNA. We are able to capture the DNA that is circulating in the blood and do the same test on the circulating tumor DNA. So imagine 5 ml of blood is able to give you the same information that an actual biopsy is going to give. But what does liquid biopsy address? Blood will contain DNA from not only the primary tumor, it will also contain DNA from a metastatic tumor or something which has spread to another organ. And not only that, it will contain DNA from many cells in the tumor. So you're already addressing the heterogeneity part of it by using a liquid biopsy. The next, we start sequencing the RNA followed by the proteomics. So you put it all together like pieces of a puzzle, the code to the messages, to the proteins, and then how is the cell behaving. So that completes the whole puzzle in terms of us getting why the problem started and how is it going to be tackled. So the promise of precision oncology, it definitely improved the treatment efficacy compared to what it was around 10 to 15 years back. Once you're targeting a particular thing and not blanket bombing the body, the toxicity is of course much lesser. There is an earlier detection by a simple blood test. So we are able to detect that circulating tumor DNA in a patient who is cured should ideally not be present, or it should be present and disappear within a few months if body is able to take care of it. Persistence of this circulating tumor DNA in blood of a person who is actually radiologically or a CAT scan or a PET CT cured patient with circulating tumor DNA is eventually going to have a recurrence because there are cells somewhere which are growing, which we still can't see, but they're still shedding. So that means earlier recurrence detection, and hence that can pave the way for long-term disease control too. So in the next 5 years, believe it or not, we are going to stop calling tumors based on where they have originated. We are going to start calling them based on the molecular change that they possess. So I might be saying something came in the breast, but it's not breast cancer. It is a cancer which has a MSI high breast cancer or a BRCA1 or a DNA change related cancer. So it is going to go to the level of molecularly classifying all the tumors in the body and does not going to carry the weightage of where it started. So that is going to be the next era in the next 10 to 15 years because all the research is going towards tumor agnostic approach where it doesn't matter where it started as long as you're able to target the gene which is responsible for it. So the economic benefits of it also are humongous. We are avoiding futile treatment with targeted therapy, reduced hospitalizations, improved efficiency of the workforce. You're able to design better trials with lesser cost in terms of to the pharma also, which will again come down to the lesser cost for the patient. And definitely it is going to be a better value-based care model. So for the patients, how is it going to help? Informed decisions. There will be a day when, like in a sci-fi movie, you're able to show the whole pathway that is acting upon the cancer and why the particular cancer is come and why is it spreading. And you're going to be able to put them in clinical trials or treatment related decisions could be made with more information given to the patient in the near future. So just a couple of examples. So this is lung cancer, which is very common in our country. Till the 90s or even 2000, early 2000s, it was chemotherapy. All the myths about chemotherapy that we would have heard were true till 90s and early 2000s. But then in 2000s came the targeted tablets. So basically we find which DNA change caused lung cancer and we started giving tablets. And within a few years, the survival of even stage 4 lung cancer, which was less than a year, has already crossed the 3 4 years barrier. We are not able to cure it yet, but a pill a day like diabetes and hypertension is able to control the cancer for 4 to 5 years with excellent quality of life. So we have moved the whole goal from trying to give chemotherapy over and over again to giving targeted therapy where the person is actually able to live a normal life, travel, have a normal social life, and then hope that we are able to improve this particular thing to a cure in the near future. Probably that day is not far away. So better quality of life too. So, and this particular thing of 1 year to more than 4 5 years already a reality in lung cancer. Even in colon cancer, it was less than a year. Now, because of all the targets that we are seeing, like EGFR, the mismatch repair deficiencies that we are seeing in the colon cancer and other targeted therapies. A stage 4 colon cancer now is able to go beyond 3 to 4 years. And stage 2, stage 3, we are able to decide who needs chemotherapy, who doesn't need chemotherapy, and when to give chemotherapy based on ctDNA. So it's all becoming a risk adapted therapy and not a blanket treatment to everybody who is under treatment. And the same goes with the other most common cancer in our country, which is the breast cancer. The one type of breast cancer has actually moved away from chemotherapy completely, and we just use targeted hormonal therapy to actually cure that particular set of patients. So if this is just an example of the trials, the future trials are all going from a single disease and a single drug to umbrella or basket trials where we are sequencing the DNA and matching the treatment to that particular DNA change. The initial trials were all negative. So the Shiva trial, which was in 2015, was actually a negative trial. People found that it didn't really benefit. You just read the book and you're getting the equal benefit. But then once we started talking about transcriptomics and proteomics and started looking at the cell in the 360-degree view, the things started changing. And now we are actually able to show clinical benefit when we started treating based on the changes in the molecular characteristics. So that brought about molecular tumor boards where we sit with the pathologist, we sit with the molecular scientist, we sequence all this data and try to project it and then try to arrive at a consensus about what is driving this particular person's cancer and then plan the treatment and even show it to the particular patient about what their current situation is and how we are going to make it better. Clinical trials, as we were discussing, has definitely moved away from the conventional ones to basket, umbrella, adaptive platform trials, and N of 1 trials is where personalized experiments for ultra rare variants, we're able to take one and still do a trial from that one person based on comprehensive data. So beyond genomics, we have already started going there. From 2015, we are no longer depending only on the DNA. We are going into transcriptomics, which we already touched upon, proteomics, the final protein structure, which is there on cells, and integrating all this and creating a personalized plan for the patient is actually what is happening. And that's where there's a large unmet need. So which we will discuss, why is there a unmet need? So artificial intelligence is coming up here. It is able to integrate all the data from all this and help the scientist in calling what is the variant which is pathogenic or disease causing. In gigabytes of sequencing, you need to be able to find actually a needle in a haystack kind of a picture where you're able to find it faster. People were doing it without AI, but now help us give out a report probably which was coming in 3 weeks in probably a week or less. So that is where AI is going to make our work more efficient and faster and probably help the molecular scientist in that particular aspect. And radiomics integration, you're able to integrate all the scans, the CAT scans and PET scans into the molecular thing and probably get a predictive model on who is going to benefit and who is actually not going to benefit and which treatment might work for a particular person. That applies to digital pathology also. Just using a pathological biopsy thing and calling out what might be the DNA changes in that particular person is one step ahead where you don't even have to wait for the DNA report. You might plan the initial treatment before the DNA and RNA sequencing come into the clinic. So early detection. So there are already FDA approved methodologies available in the world where a single blood test can, based on the epigenomics information that you get from the DNA in the blood, can predict what is the risk of having cancer in the future. It's called Reveal, or it's also called Shield. Guardant Shield is it's a company in the US which has actually gotten their FDA approval for doing this. And I think for it to be a mass screening thing might take a few years because of the cost, but I think it is going to help us catch more cancers early or even try and prevent some of them. So the future directions in this aspect is a person who's supposed to be cured after a surgery. If there is some circulating tumor DNA present, we are able to catch the recurrence way before it's going to occur and treat it and try to cure him before he actually develops a disseminated or a fully spread cancer in the body. So the next step would be obviously going into the DNA and trying to modify the DNA on technologies like CRISPR and trying to take out the body's immune cells, engineering them and sending it back into the body, something known as CAR, where it is already in practice in blood cancers, which might come up very soon for solid malignancies. So you engineer the weapon in the lab and then give it to that particular person so that the cells that you're giving, the same person's T cells or the immune cells are going to be given back to the person after a certain amount of engineering, which will go and attack the cancer cells in terms of extreme precision. So it all sounds brilliant, whatever I said, but what are the challenges? We are dealing with gigabytes of data which is coming out from genomics. We have 20,000 genes, which if we start sequencing the whole genome sequencing, it might go to gigabytes or terabytes of data when you combine it with transcriptomics, proteomics, metabolomics, lipidomics, and radiomics, whatever omics that we are talking about. So whether you're doing a single cell, bulk, or whatever we are doing, now to integrate all this and then come up with a predictive model is something which is definitely a huge technological challenge, and it includes a lot of cost at this current moment. So the high cost infrastructure, limited expertise in one particular lab is not able to do it. And if you spend so much and make a predictive model, the drug research is not yet caught up to it. So what are you going to do if you know that this is the cause and you don't have a drug? So it's good for discussion with the patient, but it's not going to help him in the clinic. So that is again a pitfall in terms of precision oncology and regulatory differences between each country. One country might take 6 months to approve a particular screening test or a diagnostic test, and the red tape that comes with certain countries is actually delaying the benefit that we can pass on to the patients. And ethical considerations where you are using so much of patient related data to anonymize all of it, including the metadata, is definitely going to be a problem in the future. So, who are the key stakeholders and how different people of different walks of life can collaborate here? Clinicians and academic centers, we need Indian industry partners for diagnostic and therapeutic development and need not always look to the West. I think our closest neighbor is a great example. They're actually surpassing the West in developing new drugs for cancers. Like I think in the last 5 years, we have gotten more drug approvals or new tech or new drugs coming from our immediate neighbors like China, even compared to the US or Europe. Patient advocates, regulatory bodies should uh, start working with the intention of making things better and not stalling them at stages where they really can't understand what is happening. And insurance, of course, has to start reimbursing the diagnostic test. That's a huge lacuna in our country. If you want to sequence the DNA and plan the treatment, they'll say we'll support the treatment, but we don't want to support the test. So, which is again a huge setback in terms of patients being able to afford these tests at this point. So, that needs also to be changed if at all we are going to move forward in precision oncology. And huge collaborations are necessary between multiple academic centers across the world. Sharing their information about the DNA data and the RNA data is only going to help another center in another country arrive at putting in place the test much faster rather than them developing their own library, because human DNA, most of it is same. Yes, there are variations from different countries to the other, but the pathogenic cancer DNA will almost have a lot of resemblances from one country to the other. So this again is a small example of how tech is actually helping us in the clinic. So there is a app called Genomate. What they do, they take the data from the doctor that we have arrived after molecular profiling the patient. It uses their proprietary software and is already making us personalized reports. After going through hundreds of DNA changes, it's able to use all this information to say for patient X, that particular lab is able to predict that this is the main thing that should be targeted first, and then the second mutation, and then the third mutation. So the personalized reporting from the data there is an unmet need in between from the data to what the doctor is going to decide. These people are coming in. So that is Genomate, which recently got a approval again from FDA to be integrated into clinical practice. So if you're talking about Indian players that we already have who are sequencing, these guys, mind you, are just sequencing and giving the data to the doctor. The doctor has to do the rest. So there are multiple labs in India too. Global leaders who have been doing it for the last 15, 20 years are the Foundation One, Guardant, Caris, Tempus, MSKCC. They have their own genomic sequencing panels that they provide to the patient. So we have to get to that level of having those libraries and having the experience to call out which cell or which part of the DNA is actually targetable. So that is where we are lagging behind, and we are fast catching up definitely compared to 10 years back. We are able to get the approvals for drugs within 6 months to 8 months of when they're being launched in the West. Even they are coming in much faster. Things are not as bleak as they were a decade back, but we are still slow to adapt to the rapidly changing landscape of cancer treatment. So, if you ask me what are the unmets today in my clinic and how I would like things to be better on a Monday morning in a couple of days, I think need to come up with a solution to integrate all the omic data, not look to the West to give us softwares to do that and create a suggestion of the driving pathway. It is a huge thing where you have to integrate all the molecular changes and come up with one particular pathway which is driving it. But there is something that could be tried in that particular, I think, scenario. So an easy interface for doctors. So this is, I think, unless you are spending a couple of years after your genuine DM or a super specialty degree, it's not easy to go through the DNA and RNA reports and actually interpret them within a couple of minutes or even let's say 15 to 20 minutes. So there needs to be an easier interface developed, probably using AI also in this particular way, where you get the report, you're able to probably show in a cell and then using different graphical interfaces, probably deep dive into the DNA change and then plan the treatment. So an interface for doctors also is not currently available. And how this particular omic data is going to be integrated into the EMRs of the hospital is again going to be a huge challenge just because of the amount of data that is coming out. And another problem with Indian, I think, medical training and the difference that I'm seeing, the way other universities, especially in the West, like the Oxford, are doing it is the way they're teaching the particular subject of precision oncology itself, I think, is way ahead of us. So they're able to create virtual labs where I can actually go learn the different steps of DNA sequencing. I can sequence the DNA virtually. I can actually compare it to the reference genome and I can learn how to carry out the interpretation of the DNA reports, which as a local Indian or made in India initiative, we have nothing in that particular subset where different healthcare providers can consume this information to make their skills or upskill much faster and need not look to the West in terms of help in learning all these things. So, to conclude, the road ahead, we need more evidence generation, rigorous evaluation of clinical utility, global access, collaborative models, patient centric care, of course, is what is going to drive precision oncology in the future. So, that was my last slide. Any questions at this point are welcome. I hand it back to the organizers.
Thank you, Dr. Sai. Uh, uh, Sushila, go ahead if you wanted to. Okay. So just wanted to sum up. This was, I think, a very nice 30 minutes of introduction. You've touched, you've taken us from the basics slowly to deep nuances. If I were to just sum up your talk for the sake of the audience and all of us, before we go to the questions and answers, I think you touched upon the challenges of the biology, right? The human biology, how the cells are so smart that each one of them is different, right? The heterogeneity being a pain, and also the fact that precision oncology promises were shown way back with CML, and that itself is a big testament to the word precision. Uh, Now, then you also touched upon proteomics, transcriptomics, which is dealing with RNA, and then way up to DNA, which is genomics, detection of those, connecting the data between those layers, and a new promising field opening up, which is called liquid biopsies, where you are able to look at blood, and it's almost like checking the drain in the house to see what's happening in the house, right? So you can look at the blood to see what kind of things are being shed or what is in circulation, and then make some educative estimates on what's going on inside. And you don't need to do a biopsy, you don't need to pull out tissue again, etc. And I think you also pointed out that in lung cancer, there was a really good example to prove in the recent times that there are wide changes. There are drugs that are specifically going to that part of the DNA chain, and actually, creating a big impact both in lung and colon. A new trend that you're also mentioning about precision oncology practice is molecular tumor boards, because this is a new field. I think there is a strong need for more collaboration, and a molecular tumor board or a molecular tumor conference in a hospital helps to discuss with pathologists and genomic scientists and oncologists. That was nice. And you touched upon trials, different types of trials, because I think we all have to go through clinical trial to make something available or to make it available in clinic, right? So I think you've touched upon some 4 different types, right? And some of them are actually coming to life, like the platform trials. And the reason why people are trying to optimize on trials is challenging criteria to enroll somebody, quickly available data to figure out if they fit, if the patient fits that scenario for the trial, and of course the cost. So there is a need to speed up the trial and also to bring the right kind of patients so that people do not endanger the trial. You did touch upon AI and the uses of AI, especially in precision oncology. I think mostly in the areas of understanding the genomic report, and that helps the clinician to action it, right? And interpreting the variant data, because the variant data comes out to be a huge, VCF file, and it's not a very easy thing for daily practice. So there needs to be more tools to break it down, and just like how you spoke about Genomate, maybe MSK, OncoKB.cc, or other types of interfaces that make it easy for a clinician to look at this complex data and come out with actionable therapies, right? You spoke about multi-omic integration, right? Response prediction. How are you feeling about a potential outcome if you were to administer that drug to a patient, right? Without that, it's going to be a huge trial and error, because these are precision oriented. There needs to be some precision in the outcome also. So I think that's a good problem to work on. And digital pathology, because I think tissue is, the ultimate truth. Typically, after imaging is the tissue and its interrogation all the way till the DNA. The pathology is now on a huge drive to digitize and to bring AI, because it's a heavily manual process until now. And now I think it's picked up. The scanners, digital scanners have picked up, and AI models on those have also taken a lot of center stage. Future, yes, you did speak about liquid, guard and reveal, for one of their screening for colon is shield. Minimal residual disease, which is a very hot topic in conferences about what is minimal residual disease. When are you called disease free, right? Is it like 0? Is it 1, 2, 10? What are the criteria for declaring somebody as disease free. Right? Uh, and then about CRISPR, which is gene editing, and CAR T, right? CAR cells, which are very targeted missiles to the cancer cells. And these are all not science fiction, and I might add, and they are really in action and they are being used. Now, where we are having a challenge is to increase their usage, to force multiply it so that it can go into more and more layers of our society. It's right now limited to luminary centers or centers of excellence, and these will need to be opened up to go to a broader population base. Challenges you spoke about, digital data, etc. So those about who needs to come together to work on this, right? So I think let's maybe have a few questions from this talk. I might add a few, and then I will probably request Abba or others to pick some questions from the chat. I might actually do that myself. Just give me a minute. So, Doctor, while I pull up that, what kind of uh, as a day in your life, right? When do you find how many times do you see you can recommend somebody for precision oncology drugs, or rather, when do you recommend and when do you not recommend? What is some criteria for that?
Um, I think I lost you for a few seconds there. So could you just
Okay.
repeat that? Yeah.
Yeah. So in a day in your life, when do you recommend a patient for precision oncology drugs, targeted therapies, and when do you feel they are not eligible, broad eligibility? Yeah.
Got it. I think at this point, like in cancer, everything starts off in the stage 4 scenario, even the treatment, and then it slowly makes its way to the stage 1, 2, 3. So when I say stage 4, that's where we know that the cancer is not curable. So precision oncology right now has the largest role in stage 4 to design a particular treatment. But in colon, in breast, in certain cancers, it's coming up to earlier stages also, but predominantly stage 4, if I have to answer your question.
Got it, doctor. Thank you. There are a few questions that the audience have posted. A couple of them are really interesting. Uh, uh, what could be some innovations in pathological models, right? What do you expect from pathology as precision? When you apply precision to pathology, what does it mean for you?
Yeah. So let's say we have millions of DNA sequenced and it is matched to that particular person's pathology report. And then you have AI coming in and it's able to, at the end of the day, look at the pathology image and accurately detect the DNA change. I think that is what I would need from my pathology in today's day and age. So look at it and even tell me what might be the DNA change, what might be the protein change, what might be the transcriptomic change. But that requires, I think, a lot of training, and you cannot make errors in that particular thing. I might start off the treatment early, but I'm still going to verify it with the actual DNA and RNA sequencing. But the day when we are able to rely on just a pathological image to predict everything about the cancer cell is, I think, something we can dream of.
Got it. Thank you. One other question about using sweat or other exogenous methods for detection of cancer. What people have asked was a question on there is work on sweat, right, for breast cancer, right? Can it be detected by analyzing the sweat? Is it possible to create a biochip, etc.,
I think
etc.?
definitely sounds fascinating, and I think that's where the field of I think proteomics and metabolomics comes into the picture. So the one of the hallmark of cancer is the metabolism of a cancer cell is different from the metabolism of a normal cell. So an abnormal metabolism happening secretes abnormal chemicals into different body fluids. So if you're able to capture that particular chemical that is being secreted into the sweat, which is happening only in breast cancer cells, yes, there is work going on like that for sweat urine, feces, everything which is easily available, but not yet completely validated enough to say we are able to pick it up in with high sensitivity. Theoretically, it sounds very fascinating and it can be possible because of metabolomics that's going really fast.
Got it, doctor. Thank you. One other question: is there a chance of hereditary relationship for cancer? If parents had, or in the bloodline anybody had cancer, there's a chance for kid to have it. What kind of, what's the recommendation if there is a family member who suffered from cancer or is suffering from cancer?
Yeah, so I think 15 to 17% of all cancers in the world are hereditary. 85 or not. That means 15% might have gotten that error in the code from their parents, one of their parents. 85 would have developed that error after they're born, not hereditary. Okay. So in 15%, it needs a bit of evaluation where you draw the pedigree or the family tree in a particular clinic where there's a genetic counselor. You see what cancers are running in the family, and then we are able to actually order a set of tests which might pick up what is the DNA change. So it cannot be done as over the counter thing for everybody, but it requires a little bit of understanding into what cancers are running in the family.
Got it, doctor. And so the best is to go to their doctor and ask for next steps,
Yeah, just
and
go
then
to the
assess the
doctor and
risk.
talk about the family history of different cancers. With the help of a genetic counselor, the oncologist will be able to predict what are the tests that are necessary. And if you detect them, I think there is a thing called Angelina Jolie effect, I think, which is true in the world. She was able to detect that she has a mutation in a BRCA gene, get her breast and her ovaries removed many, many years before the cancer could come. So that is called risk reduction, which can be done.
Thank you, doctor. One other question is about in the talk you had said the cells are heterogeneous, right? And you're using, do you use the genomic signature for treatment? Does it answer that heterogeneity, right? Does it work on all the types of cells? What is typically the treatment strategy when you have cells which are different, and then you have a very sharp answer for genomic finding?
Yeah, I think that's a good question. So right now, that's the problem of stage 4 cancer. When you say stage 1, 2, 3, let's say there are only two types of cells in the particular mass. One, they've removed by surgery and they're very minimal in the blood. But in stage 4, the cancer has stayed in the body for enough time so that you can have around 15 varieties of cells which are activated in the body. You then start to look at a genomic signature and give it a name called driver. Okay, and the other ones are called passengers. Right now, we are targeting the drivers, we are getting responses, but certain cells would have already evolved enough to fight off the treatment. So, 100 bad cells on treatment for that particular driver might become 20. The question that comes here is, why are those 20 still persisting? Why didn't they die with the 80? Because they have acquired something to fight off that treatment. And with time, these 20 will stay quiet for a while, a year, 2 or 3, depending on the cancer. These 20 will become 100 again. So then you find out the thing which is driving this 20 and attack it. So that's how it's a to and fro thing in stage 4. Hence, we are stuck.
Got it. Uh, there are some young students who are asking some questions who are from computer science, right? Fourth year computer science, and asking what from a computer science student background, what kind of a difference can they make to this field? Do they need any specialized training, etc.? Does it? I mean, what can they contribute, as part of their projects or as part of, their training? What could be something that at their academic journey can be solved?
I think the computer science guys, I think, should be able to get access to, I think, institutes like IISc, where we need to start having sensors which are there in such research institutes, where you start sequencing the DNA en masse, RNA en masse, proteins en masse, bring in the computer students from our tech universities, and try to build a predictive model, like a flight simulator kind of a thing, where before giving treatment with the data available and with the drug you want to use, if you're able to predict what is the chance of 90% of the cells dying, what is the chance of 100% of the cells dying, the predictive models, I think if that is able to be done with such accuracy, I think that's where I think our IISc and IITs, I think, could play a huge role in pushing this forward in our country. We have the most brilliant minds in the world, but the research is happening in the West.
Correct. Maybe a last question, doctor, just keeping to time, or one or two. Uh, so, in our country, what happens to rare cancers, less studied cancers? How is precision oncology helping them, right? Because those are rare, there is less data, guidelines are less. What's the current strategy that is used to manage those?
It's the same strategy again. As I was mentioning, cancers are no longer going to be called by the name. Let's say a sarcoma, we say, is very rare. Just to quote an example, we are still sequencing the DNA and RNA. We are still finding some mutations. Let's say we have a rare sarcoma which has the same DNA change as a colon cancer. So we are treating it like a colon cancer, not treating it like a sarcoma. So that is the whole essence of precision oncology here.
So you're at a level where it can deal with a whole lot of variants of that, right? You've gone down to
Yeah.
potential root cause,
Yeah.
all its manifestations, like a sarcoma or an adenocarcinoma or whatever, can be handled. Right?
Exactly. But again, I think I've oversimplified it. It's not as
Yeah.
easy as I'm seeing it in the clinic. It's not yet there. That's the whole dream, because we are getting mutations in sarcoma. Unfortunately, there are no drugs for it. So again, pharma needs to catch up at that pace at which diagnostics is progressing. We are again, that's a hard stop for the clinician, where I can only discuss with the family, hey, this is what is unfortunately the cause of this particular problem. There might be a trial happening somewhere in the world, we can guide them. But even that again is still not accessible to many people in our country.
Got it. Last question, and I'll probably let you go because I think you have some. You're in between you're giving talks at a conference. Uh, so this is a question on AI. If somebody wants to develop certain predictive models, uh, what can they expect? Let's say they want to, approach a hospital or hospital chain or whatnot. Typically, what could be available and what is typically collected that can be used to predict a model? Like, do you have digital pathology? Do you have their labs, their genomic test outputs, etc.? What is a way for them to enter this area with
I think,
hospitals?
yes, there's a lot of data privacy which comes into place here. Unfortunately, the laws are so strict that you
Yeah.
cannot reveal the identity of the patient in any way. So it requires some paperwork and all that stuff. But yes, once you get through those barriers, I think you will get the digital pathology photos, you will get the CAT scan reports, you will have the files of all this sequencing and what type of cancer and the clinical history and everything after it is anonymized. Now, what to do with it, how AI is going to help integrate all this is the thing I think we need to work out.
Yes. That's the promised land.
Yeah.
I think these are broadly have covered most of the questions that the field asked. Maybe we'll end on one last question about immunotherapy. People have been hearing this word immunotherapy
So,
and the MABs. Could you shed a bit of light, and then we will let you
yeah,
go.
I think, yeah, there's a lot of confusion about immunotherapy and targeted therapy. So I'll just break it down. So as we say, targeted therapy, as the name is so simple to understand, you're finding a target and you're attacking it with a particular drug. Likewise, immunotherapy falls under the umbrella of targeted therapy. Okay. Immunotherapy is targeted therapy, but all targeted therapies are not immunotherapy. Okay. So in immunotherapy, we are using a very simple principle that all of us have immunity in our body. We have B cells and we have T cells. T cells are ideally supposed to detect anything foreign whether it is cancer or viral or bacterial, it doesn't matter, and destroy them. So that is the whole purpose of having T cells. But yet, why are cancers developing? The cancers are so smart, they are secreting decoy proteins which are fooling our own immunity, saying, hey guys, don't attack me. I'm just like the other cells. So, immunotherapy is a drug or a simple treatment which is given periodically in a bottle of IV, where we are targeting the decoy proteins. We are not targeting the tumor, not targeting the immunity. We are just removing these decoy proteins using a targeted medicine, hence hoping that our immunity wakes up so hard, it starts producing innumerous cells and the immunity itself fights the cancer. So that is the premise of immunotherapy. It is very good for certain cancers. It's now there from head to toe. To be put it short, we have immunotherapy recommendations from the tongue cancer to probably a melanoma, which is arising from the foot. So immunotherapy approvals are there for everything, but we are still not able to find out if you give this immunotherapy to 100 people, the theory is correct that the immunity should get stimulated, but it's happening in only 40 to 50% depending on cancer to cancer. So why that is happening? Probably there are so many DNA changes which are occurring in the cancer cell that even immunotherapy or our own immunity is not able to fight the cancer. The cancer has outsmarted our own immunity. So that's the whole thing about immunotherapy and targeted therapy. Lot of myths going on, lot of quacks also are advertising that we do immunotherapy, and there are small centers cropping up everywhere. But actual immunotherapy is given only by qualified doctors, and there are only four drugs. There is no oral immunotherapy. I was debating with a patient yesterday saying, apparently their relative is receiving oral immunotherapy. I said there is nothing called oral immunotherapy which has been approved in the world. So it's like there's so many myths going around. Immunotherapy is an injection given over an hour periodically. Only four or five are available in the world.
Types of treatment.
Yeah.
Yep, got it. Thank you, doctor. Thanks a lot for your time. And actually, you opened a nice can of problems that people can work on, right? And in this series, I think we will see you once more later on a panel when we have clinicians, academicians, and management personas there. Yeah? So with that, I would thank Dr. Sai Vivek and let him go. And then we can.
May I, Ravi? I just
Yes,
want
yes,
to
yes, please.
thank you, Dr.
Yeah.
Sai, for this. We know that you've taken time off in the middle of a lot of other, between presentations and so on. So really, from the bottom of our hearts, thank you for being here. Also, as Ravi said, we will look forward to collaborating with you a lot more, not just in the webinar series, but beyond that as well.
Yeah.
So thank you again.
Thank
For
you.
our audience, we will continue with part 3 of today's webinar, which Ravi will be taking us through a little more in terms of details as well as technology.
Yeah.
So thank you again, Doctor.
Yeah. Thank you.
Yeah. So I think with that, what we will try to do now is to connect the dots with this talk and the previous talk, right? I thought maybe that's an easy way to internalize this. And there were some questions on data and models, etc. I might be able to add a bit there, and then we can see if that helps. Right? It's anyway going to be a dialogue. It won't get done very soon. So let's just go back to the previous sessions deck so that we can put this in context. Right? So let's get to this, right? Dr. Sai Vivek spoke about genomic reports, a lot of data and things like that. That's true. From a genomic test, which is usually taken from a tissue, you would get so much data, it's in gigabytes with it's text patterns, right? It's a bit like how you see in the movie called Matrix, in their You see a lot of screensavers like with 101010 all dripping all over your screen. It's just ATGCs, ATGC, just four things. That is all that's available for writing our code, right? You have AAA, it means something. ATT, it means something. TTT, it means something, right? Huntington's is diseases have some of these patterns, right? So these are some examples of vendors who do genomic testing. In India, we have, as Dr. Sai was saying, we have 4 or 5 places where they do that. And that is generally recommended by the clinician if they know that there is a good chance that you would benefit. If you are a patient, you would benefit from genomic testing, right? So what are simple elements of this, right? We'll just look at it at a high level. Genomic reporting is also new, meaning not all clinicians in tier 1 and tier 2 have had the opportunity to administer or prescribe the drugs which are precision based due to various reasons, which is why when a genomic testing vendor gives a report, they also write on how to interpret the report so that the report is standalone. So there is a lot of text that follows that as to why they wrote what they wrote. So if you see here, it has got some sections here, right? And what you're seeing in the bottom is like for all the data science folks here, this is a data model for capturing the genomic part of the oncology data, which if you're a data scientist, which if you want to represent a genomic test report, you would want to extract and populate this. Why are we talking about this? Because we saw the unmet need of multi-omic data aggregation, right? Likewise, there is a data domain for pathology. There's a data domain for radiology, and it's a data domain for treatment, and one for response. So if you populate such a comprehensive data model, the chances of finding cause and effects and helping the clinician are much, much higher, right? So the whole point is to see if you can take the patient data, organize them in an addressable form, programmatic form, data model, this is governed by, or this is a forum called FHIR, Fast Healthcare Interoperability Resources. They have realized that capturing data for representing the domain is important. So the oncology group of the forum started to recommend data capture, which helps such research and science and even for clinic use. So what they have defined is called as M-code, minimum common oncology data elements. So you know what you need to extract from the patient's data. If you don't know what you're looking for, then it's a hard problem to solve. So therefore, you have these data, discrete data elements. Some of these are not really discrete, they're also compound. But the moment you capture this, you start figuring out the richness of the multi-model data, right? If you see, for example, this is a patient who has a certain pathology type and its subtype, right? And then you see that this patient underwent some kind of a proteomics study or a immunohistochemistry study, which basically tells you what is the immune system sensitivity, right? And what will it respond to and all that. That's, I'm simplifying it. Immunohistochemistry is trying to find out immune status using biochemical stimuli and studying the response. Right? Typically, it is a stain. It's a protein stain. You see how the protein stain is taken over by the tissue and then you will see that it is such and such type, and then people will administer treatments based on that. So the moment you see this entire pyramid of data that Dr. Sai was describing, the decision making becomes a lot easier only if you simplify that so that it can be consumed easily, right? Uh, that's one of the things that healthcare suffers from, which is lack of dimensionality reduction. If you have one data of a certain dimension, maybe you can reduce the dimensionality. Like take newspaper. Assume that the newspaper had no headlines, no color fonts, just flat text. Would you ever read that? Well, you will read only if you're under some severe pressure, right, or anxiety. Otherwise, you would not read such a fat pile of paper with flat font, and you don't know what to look for, you don't know what's catching your attention, etc. So that's one of the advancements going on in the data modeling in oncology, because that is the route for driving research and for actually driving AI models, or for driving cognitive models to see how you'll help them to find the cause and effect in that whole chain of data, right from their symptoms, radiology, their labs, and then their uh, bloods, right, tissue, tumor markers, etc. Right, all of these are telling you something, and you need to put that together, and that's when a clinician will make a decision. They will never act based on single dimension of data, even if it is screaming at you saying, hey, I am this gene, I'm this, they will not act on it because it is a single dimension. They will look for other dimensions. Yes, they may be more precautious in monitoring the patient, and then act when it is necessary, when the body is starting to say, yes, I am not able to manage that myself, do something for me. Because many a times these are all dealt with by the body's immune system in different mechanisms of action. Therefore, they do not act on any singular dimension, even though it's a very narrow, dimension of data like genomics. So if you see here how they really look at it, because this topic is precision oncology, and precision, the ultimate precision is going down to the genomic mutation level, and that's basically what your body is telling you. So if you see on the right here, these are the ultimate important markers, right? Let me just, yeah. So this is the one of the most critical part of a report. You'll find that in many vendors. You'll find a bunch of these like this. Let's quickly touch upon what these means, right? Because this also involves a certain amount of smart large language model based extraction, etc. So look at this. What this is basically saying is, I have taken your tissue, I have run it through next-gen sequencing, and here is the status, immune status, or here are the important biomarkers that you want to look at, and here, I'm reporting these to you. So what it's basically saying is that this is at a certain level, slightly higher level. There's a tumor mutational burden, almost a rate of change of how the tumor is changing, and something about the tumor copy numbers, or it's tumor's microenvironment status, and it's saying what kind of a drug, sorry, what kind of a gene. Now it's getting down to genomic level. These are macro findings, these are micro findings, for sake of simplicity. The micro findings are that there is a BRCA1 pathogenic mutation at such and such place on the gene and then on the exon, right? And there are some drugs that are recommended or cleared for this kind of a gene mutation in breast cancer or lung cancer. This is a lung cancer patient. So BRCA1, by the way, there is another myth that BRCA is only for breast. BRCA, BRCA1 and 2 are part of all the 10,000, the 25,000 genes. And these play a role in almost any other tumor, right? These are at such a level that it has no direct connection to tumor. Any of them could trigger a pathogenic change. And these are the 3 drugs that are available based on the level of evidence. Okay? And if it's got a lot of evidence, then the doctor typically recommends it, looking at a few other parameters, such as whether the patient can tolerate, if they have some predisposed comorbidities. And these are the most favorable things for the patient. Right? Let us say the patient is not able to take these because of some contraindications, or they're ineligible to take these drugs even though they've got this mutation. Then the second choice is that the doctor sees not in lung, but did any other cancer type, did they use a drug to rectify this problem? So it looks like in some other tumor type, not lung cancer, talazoparib has been used to overcome this pathogenic mutation. So these are the actionability tables, right? These are the 3 genes that it found to be pathogenic. And based on which gene is most highly actionable, they would use that as one of the criteria to recommend to the clinician, right? So if you see here, TP53, right? It's the famous gene. This drives our cell killing pathway, right? So this has no actionability, meaning, yeah, you found it, but there is really nothing that I can do specifically to correct that, right? So that's one of the ways of doing it. You saw the second one, there is no directly eligible drug in the patient's lung cancer, but in some other cancers, they have used sorafenib to treat the pathogenic mutation of this gene, right? So that's a quick high-level understanding of this actionability table as how a clinician reads it. And any of you who are into AI, data science, data modeling, I would urge you to look at MCode. Just Google MCode. You should be able to go and see this data model, and you will realize that there is a more comprehensive data model with color-coded domains, and the focus is on extracting or populating that from patients' records. In the future, these will be directly populated when the hospital's EMR or patient health record is able to do so. Right now, the challenge is that they cannot fill such fine-grained information. Therefore, they would need to use LLMs or other methods to break down that and then put it into this data model, right? I will probably pause here, and maybe I will request either Sushila or Abha to see if there are any questions that are coming up in the chat. We could take some of them. Otherwise, I'll just probably go to one other aspect of what Dr. Sai was talking about.
Okay, so maybe few general questions from my side. It's wonderful presentations. Both the presentations are really very insightful and knowledgeable. I think for even you're not aware of many things, but now I think the knowledge is very deep, which is provided to all the audiences. So in terms of like, when you're talking about these specific medicines, so I think the first question arises is the availability, means how hard or easy. Of course, not easy, but if it is hard, then how hard it is, means how long it takes to be available, and if these the medicines are covered by the insurance and those aspects, if you can talk about.
Yeah. So quickly, I think Dr. Sai touched a part of this. The insurance companies right now in India are covering for the treatment, some of them, but are not yet covering the tests that are required to give this treatment, because this treatment is very, very focused. So you have what is called a diagnostic treatment pair. Okay. If this diagnostic is positive, only then can you give the drug. Or in other words, if you want to give, say, in the previous example, we saw talazoparib or olaparib, right? That olaparib comes under the class of PARP inhibitors. You can look up, it's one type of drugs which are meant to deal with a certain fault in the DNA, a different type of a fault. It's called HRR, homologous recombination defect or so. So to administer olaparib, there has to be a certain test done to yeah, let me zoom in here and then it's here, yeah. To administer olaparib or niraparib, you need to do an HRR test. Only then that drug is allowed to be administered, because it's meant for a very, very specific purpose, right? So that is one. The second is, as Dr. Sai was saying, it takes around 7 to 8 months for a drug from the West to be made available here. Now, that connects to the previous session where we're talking about data, right? And clinical trials. For the people on this call, there was an important question that was asked last time about data and data availability and anonymization and de-identification. And it also connects to the type of trials that Dr. Sai was speaking about, right? N of 1 trials, basket trials, and all of that. Ultimately, a country, to frame its policy, needs to show or asks the drug company, to show that their drug does not have harmful effects beyond whatever is labeled on their drug for their country population. So for the Indian gene pool or the Indian population, with their lifestyle, their ethnicity specific changes, I hope we all realize that our body functions and our anatomical structure is different from a Caucasian person's structure. Absolutely. And is different from an Asian race pool and from African American races. As a simple example, Indian coronary artery is much thinner than the Caucasian person's coronary artery. It's like half the diameter. Our pipes are thinner, basically. And likewise, our kidney functions are different because we all evolved in different environments for different purposes. So you'll need to ensure that the new drug is working within the bounds of what it is promising, good and bad, right? And they have to conduct a trial. To conduct a trial, you will need to recruit patients. Now, to recruit patients, you need to know which kind of patients you need to recruit. For an oncology hospital, which is a big hospital, sure, they sort of have an idea of who are there, how many are there. But for you to do it in a larger population, because the strength of the drug is the strength of the data, is the strength of number of people samples, right? It correlates. It's pretty hard in that sense to get, such a large enrollment. Right? And this is one of the biggest challenges we have in the country. As I was speaking before, we are all yet to create normograms, or what's normal, what's a data collection for saying what is normal for Indian population. It's evolving now, Indian gene information, etc. Because 120 by 80 blood pressure may not be our normogram. It's debatable, right? But people use it right now because of lack of any other normogram. And you all know, based on age and profession, with the 120 by 80 normogram changes. So when we are trying to interpret our own blood test report, sure, for the sake of curiosity, we might interpret the tendency is to quickly go and see which are out of range, right? And then worry about it. But age appropriate changes or results are generally found by clinicians. So we should rely on them to tell us what's going on, because we don't have an easy gene pool or a easy normogram or lookup table for Indians to plug in and see good or bad, right? So I'll probably pause here. Any other questions from this, or we should hand it back?
You can finish the next slide. So
Okay, yeah, and this is also another type of sample. I can probably just touch upon this a little bit about resistance, right? Dr. Sai was also saying in his talk that there needs to be prediction, right? If I am going to give this drug, yes, the test came out positive and you need to give the drug, but do I know if it works with that patient or not, right? Maybe that patient, 80-20 rule, right? 80% of cells died, 20% did not die. Why did they not die? Because they lived in the body long enough to learn about the systems and figure out a decoy. By this time, you all know that the cancer cells are smarter than the normal cell, right? They become smart. When they become smarter, the human immunity system is not able to deal with it. It looks for external support. One of the supports is to remove the facade or the fake decoy mask that those cells are wearing, and then you can send your regular T cells and soldiers to go and kill it. Right? So in the genomic report, you will also see potentially if you have resistance, and the drugs that are generally the drugs that are suitable for you, it also will list whether you are resisting them or your body is going to resist it because there are other genes that might not allow that drug to reach the right targets. So this is basically what I wanted to say, that there is also a matter of resistance, which is what differs in people groups from people groups, right? So there's work going on to catch more information and ensure that when you present a multi-omic view, you also tell that these are the drugs that are eligible, but half of them are not because he has a resistance gene that won't let him benefit, right? So I will pause here and we can use this time to sort of conclude, and then please do give your feedback to the organizers. Thank you. Over to you, Abha and Sushila.
Thank you very much, Ravi. I think there is one more question on privacy and open source foundational models. Would you like to address that?
Okay. So this question is on open source foundation models. Yeah. So privacy aspects, right? First and foremost, I mean, there are 2 or 3 things to privacy. It's a big topic. Maybe we should spend some more time, which might help. I would urge some of you to actually look at how the longitudinal data looks. Now, privacy is about ensuring that any data elements that may be re-identified to that specific individual are removed. Right? That's the definition for healthcare privacy, or PHI. In privacy, you will need to see if you can find any mentions of identifiers like patient identifiable PII information, right? And you'll need to mask them, or you need to put a pseudo term there. Right? And to do that, if you have a table, you have a nice structure, you have all the key value pairs, any software engineer, can quickly do that, right? Replace the actual thing with a pseudo thing and move on. But there is a tendency for people to write, such things into the reports and free text, and you need smarter methods to identify that and to mask it, right? And that's one. The second is, if you are a rogue actor in the chain and you're trying to re-identify, if you take their patient data like CTs and MRs and this and that, you have dates of admission and all that, you can go back and find out who the person was. And such things have happened in the past. Therefore, it's highly recommended that you pseudonymize, or you de-identify in time and space, right? So let's say this patient's episode is from 2nd January of last year, 2024, till, and it's going on, right? Now, you could consider shifting the entire time frame to 5 years ago, or you don't tell how much, right? The hospital decides how much they should shift. You should randomize using an offset. So that's the another aspect of privacy. I will need to get back on OSF models. I will need to see how it works, right? It's a good question. I will get back. The same is the space for a biotech engineer. We can touch upon that. Sometimes we do workshops in hospitals and engineering colleges to bring people together. But I'll leave it to Sushila to see if something needs to be done in that space.
Yep, absolutely. I think we could consider doing something at the IITACB. We are always looking for opportunities to solve big problems, and how we can, especially using technology in science and technology. And if this is an area of interest, which it clearly is, and the other question around cross-functionality of solutions as well, we can certainly look at running some workshops, training programs, and so on, both online and physically at our center. So that is something we can discuss separately and hopefully action as well. So today has been, again, another fascinating episode in the series. We started with Dr. Sai Vivek telling us about the huge challenge that cancer is because of the complexity of the disease. He started by explaining the heterogeneity of cells, both through temporal and spatial transformation, and what that really implies. How rapid changes to DNA take place, and which is expressed as genomic instability. And that is the reason why it is so hard to treat cancers. The other point he made was that tumors are changing at such a fast pace that they are beating the evolution of treatments. that is obviously a big challenge. He described what precision oncology is, which was the topic of today's discussion. And all the way from diagnostics to targeted treatment based on the many omics of the specific individual. And we saw what those are, what are the various many factors that play into diagnostic and treatment. There has been rapid progress in the last decade, but without technology supporting it, clearly it would just not have been possible to do precision oncology or even get us to where we are today. We saw details of the many factors that need to be taken into account at each stage of the pathway, starting from diagnostics and going all the way to treatment, and further vigilance as well, because to make sure that the long-term disease control happens, and that really is the goal of precision oncology. Dr. Sai described the evolution of the field of oncology, and a few points there. We now know that tumors are organ agnostic, and so that's going to even change the way cancers are going to be named in the future. By tracking all the various omics specific to an individual, to a patient, it is possible to understand how the cancer is progressing or happening. And this is what will help match the treatment to that specific instance of cancer. I think that is probably the area, the understanding that has evolved over the last few years. Clinical trials themselves are changing and moving towards an N=1 kind of a trial. Predictive modeling at an individual level is another area, again, impossible without a lot of technology going in. And we saw examples of those technology tools in Ravi's talk. We saw a detailed look at the Foundation One platform, CRISPR, which looks at changes to the cell biology, CAR-T, and then Dr. Sai Vivek showed us an example of the Genomate app and how it gives a personalized report at the end of it. There are very many challenges, and some of them are the drug safety and effectiveness specific to our population and our genetic profile. The huge quantities of data, very disparate, which need to be pulled together and made sense of. Ethical privacy considerations. This whole thing is a very multi-stakeholder effort. Academics, industry, regulatory bodies, insurance, global networks, global data, and what's happening there. All of that needs to come together for us to make sense out of it. And then there is medical training, which again needs to undergo change to incorporate things like precision oncology. And of course, most importantly, it has to be completely patient-centric. So that is a big change that has to come into the way we look at treatment, diagnostics and treatment, actually. So thank you for this again, Ravi. This, and Dr. Sai, we'll of course, we did thank him, but we'll thank him again.